This is part 2, chapter 42, diseases of the GI tract. Okay, one of the major problems you have to ascertain when you have a patient with vomiting, nausea, or abdominal pain is are they having an obstruction? Intestinal obstruction and ileus. Intestinal obstruction, any condition that prevents the flow of chyme through the intestinal lumen. The clinical manifestation of intestinal obstruction is colicky pain caused by intestinal distension followed by nausea and vomiting. The large intestine obstruction is hypogastric pain, abdominal distension. So just to review about nausea. Nausea is usually physiologically a symptom or presentation of when the motility of the intestinal tract stops. Normally the waves of the intestinal tract move in successive waves, and it's ongoing, continuously, slows down at night, almost never stops. When it stops, completely stops, the feeling of nausea is this absence of motility. So intestinal obstruction treatment, replacement of fluids, electrolytes, gastrointestinal suction, NG tube, sometimes that's all you need to do. One of the major causes is adhesions from laparoscopic procedures. It can also be a symptom of strangulation or complete obstruction requiring surgical intervention. It can be malignant obstructions, can be pseudo-obstructions, such as parasympathetic. Okay, so intestinal obstruction illnesses, types of vomitus can indicate the location of obstruction. So if it's the pylorus, which is the opening of the stomach into the small intestine, there's early profuse vomiting of clear gastric fluid. If it's proximal small intestine, a mild distension, vomiting of bile stained fluid. And lower small intestine, pronounced distension, greater length of the intestine is a proximal obstruction. Vomiting may occur later and contain fecal material. That's very rare. It looks like fecal material, but it's not really. Intestinal obstruction, ileus. Simple obstruction, presence of a lesion. Functional obstruction, paralytic ileus, failure of motility, especially after surgery. So small intestinal obstruction, most common, fibrous adhesions. I've had surgery before. Almost always related to previous surgical procedures. It's rare for people to have a small bowel obstruction that didn't precede surgery, that surgery didn't precede it, and if it does occur, then it's usually caused by some kind of mechanical obstruction like a cancer or something more unusual. Large bowel obstruction, most common, colorectal cancer, vomiting, volvulus, and acute chronic pseudo-obstruction, overleaf syndrome, mass dilatation of large bowel. The patient can be critically ill. This is some x-rays that I put in here for you to see. This is called air fluid levels. These lines right here. This is air in the intestine, small intestine, and you can see this line. So the air is floating on fluid, air fluid levels. And you can see that this arrow points that the normal lumen of the bowel is bigger than it should. You will know that. And if it's dilated more than 3 centimeters, coil spring signs and other things you don't really need to know. This means it's kind of compressed. And no gas in the colon. So if you look down here, normally you would see gas in the colon, and you don't see any. This is an x-ray of what is the diagnosis. This is a dilated colon. In effacement of the half strip peripherally located. These folds are spread apart, and there's multiple air fluid levels. See? These are all air fluid levels. This is a large bowel obstruction. This is quite... Okay, so these are some pictures of intestinal obstructions that can be caused by... this is a herniation. We have bowel go through a hernia. So this is maybe the umbilicus, could be inguinal ring. And you'll notice that this drawing shows that this is inflamed in red, meaning that it implies that there's a restricted blood flow. In B, you can have an adhesion, which we talked about, right? C is a volvulus, meaning it's a twisting of the bowel. And then D is an intussusception. So all these can occur, types of obstructions. Which statement is correct regarding disorders? Motility, dysphagia causes hematemesis? No. Cessation of splash syndrome occurs in pyloric obstruction occasionally. Achalasia is a type of referred pain to the esophagus? No. Achalasia is immotility of the esophagus. An obstruction of proximal small intestine causes vomiting of proximal small intestine, fecal vomiting? No, because there's no feces in the proximal small intestine. It's only feces in large colon. So, chronic fungal gastritis. This is a type of gastritis. This is immune type, type A, associated with antibodies, parietal cells, intrinsic factor, resulting from gastric apnea and pernicious anemia, vitamin B12 deficiency, right? So this is the type of gastritis that you see in elderly people because vitamin B12 deficiency, pernicious anemia is more associated with that. Chronic antral gastritis is non-immune type B associated with H. pylori, non-steroidal anti-inflammatories, alcohol, and tobacco. Just remember that the mixture of this and this can be quite lethal. Even though read the bottle label and say that you can have 2 or 3 drinks a day. People who are having 2 or 3 drinks a day usually have many more than that, and it's not likely that they can get significant GI bleeds. And I had a patient who we missed the boat on, we sent home, and he came back in with a big GI bleed and eventually succumbed to it when using NSAIDs, and we didn't know how much alcohol was. So gastritis is an inflammatory disorder of the gastric mucosa. Acute gastritis is associated with Helicobacter and non-steroidal anti-inflammatory drugs. Clinical manifestations: vague abdominal discomfort, epigastric tenderness, and bleeding. Treatment healing usually occurs spontaneously within a few days. Discontinue drugs, diminish antacids, and decrease acid secretion with H2 blockers. Chronic gastritis manifestations as well for correlate with severity of the disease: anorexia, fullness, nausea, vomiting. Treatment: smaller meals, soft bland diet, avoidance of alcohol and NSAIDs, administration of a combination of antibiotics, vitamin B for pernicious anemia. Just remember, chronic gastritis is probably an indication of some other major social, economic problems, and so you really need to make sure you have a good understanding of what the cause is. This is what gastritis looks inside the stomach. All these hyperemic red spots are not normally. This is how the stomach normally looks. It's got a pale yellow. These are all inflamed, and all of these spots the patient can bleed. Alkaline reflux gastritis is stomach inflammation caused by reflux. Alkaline pancreatic secretions. Clinical manifestations are nausea, bilious, vomiting from bile, meaning bile, vomiting which contains bile, sustained epigastric pain, worsening after eating. Treatment: avoid aspirin and alcohol, low-fat diet, and possible surgical correction. Peptic ulcers break down ulceration of the protective mucosal lining of the lower esophagus, stomach, and duodenum. So it's acute and chronic ulcers, superficial erosion versus deep. And one was often confusing because we just talked about gastric ulcers, chronic and acute, and now we're talking about peptic ulcers. And they terms sometimes are used intermittently, interchangeably. There is a genetic predisposition to this, as the H. pylori function, end stage, but there's also excessive use of alcohol, smoking, acute pancreatitis, chronic obstructive pulmonary disease, obesity, and being over the age of 65. So peptic ulcer disease is the upper part of the stomach, just like it says, the lower esophagus, stomach, and duodenum. Back here you can see all this inflammatory process. This is the normal color of the stomach. These are all much redder. You can see there's blood in here. Patient's bleeding from here, or had been bleeding. Duodenal ulcer is the most common form of peptic ulcers. So this is how you can best not get confused about it. So peptic ulcers can occur anywhere from the esophagus down to the duodenum, but most commonly it's in the duodenum. And developmental factors alter mucosal defenses, high gastrin levels. Gastrin is what a hormone helps produce acid in the stomach. Rapid gastric acid production caused by cigarette smoking. Chronic manifestation, chronic intermittent pain, epigastric pain usually begins 30 minutes to 2 hours after eating. Pain is relieved by food and this is a kind of diagram of what we saw, the picture we saw before. This is the pyloric valve sphincter right here, and this is the duodenum, and here's the ulcer, and this is what it might look like on the endoscopy. Treatment: acid neutralized gastric pH, proton pump inhibitors. Risks of duodenal ulcer may reduce with diet, high vitamin A, C, zinc, and selenium. Trends in development antral regions of the stomach and the adjacent acid secreting body. Pathophysiology, usually H. pylori. This is the antral region is in the stomach itself. Primary defect: increased mucosal permeability of a hydrogen ion, and gastric secretions normal or less than normal. This is how H. pylori interferes with the mucosal damage with non-steroidal and other indicators. Clinical manifestation is pain immediately after eating, tend to be chronic, anorexia, vomiting, weight loss. Zollinger-Ellison syndrome is associated with a gastrinoma. It's a chronic secretion of gastric acid. And gastric duodenal ulcers. Clinical manifestation is gastroesophageal reflux with abdominal pain and diarrhea. Treatment is proton pump inhibitors, reduce gastric acid, surgical removal of tumor, and to limit metastasis. So it's all analysis. You might run into that. Stress-related mucosal disease is peptic ulcers related to severe illness, multi-system failure, and major organ trauma. These are the people who start to bleed after having septic shock, major trauma cases. Ischemic ulcer develops with hours of the event. Curling ulcer develops after a burn injury. Cushing ulcer develops as a result of head trauma. And clinical manifestation of bleeding, most common treatment prophylactic. Then we move into another area of dumping syndrome. There's rapid entering of the hypertonic chyme from the stomach into the small intestines. It's usually a complication of partial gastrectomy bariatric procedures. So we're doing more and more of these, and this is going to be pretty common in clinical practice and primary care. People who've had gastric bypass surgery for obesity, you might even refer people. They come back, everything's fine after surgery, and then a couple of months later they start to develop dumping syndrome. Development factors: early dumping, loss of gastric capacity, loss of empty control. Clinical manifestation is diarrhea, cramping, and feeling epigastric fullness, pain, and nausea. It's usually associated right after eating. Late dumping syndrome, 1 to 3 hours after eating, weakness, diaphoresis, and confusion. Treatment for early late dumping: consume frequent small amounts of high protein, low heart rate diet between meals, recline on the left side after eating, and octreoside is also very helpful to inhibit insulin release and slow intestinal transit. Malabsorption syndrome is interfering with nutrient absorption, maldigestion, malabsorption. One of the malabsorption syndromes is pancreatic insufficiency, insufficient pancreatic enzymes. You probably recall that the enzymes that the pancreas secretes lipase for fat, amylase for protein, and trypsin and chymotrypsin for protein also. Causes pancreatitis, pancreatic carcinoma, pancreatic resection, and cystic fibrosis. One of the more common illnesses of genetic illnesses. So fat maldigestion, primary problem, most common signs: fatty stool, weight loss, treatment with lipase supplements. Lactase deficiency is a congenital defect in the lactase gene, inability to break down lactose into monosaccharides. fermentation of lactose by bacteria causing gas and cramping and osmotic diarrhea. So the best thing is to avoid milk products, lactose-free diet, and use lactase enzymes. Bile salt deficiency. Conjugated bile salts are needed to emulsify and absorb fats that synthesized from cholesterol into liver. As a result of liver disease, intestinal stasis, and it leads to poor absorption of lipids, causing fatty stools, diarrhea, and loss of vitamin A, D, and K, the fat-soluble vitamins. Treatment: medium chain triglyceride diet. That's a substance you can order and put into their diet. Parenteral administration of A, D, and K, and malabsorption also continues with fat absorption, vitamins A, night blindness, vitamin D, calcium absorption, K, prolonged trauma from any testicular atrophy and neurogenic